call for the order. Roll call.
Acting Chair Garza.
Present.
Director Sorrell is absent. Director Webster Cross. Present. And serving as a substitute member, Director Story.
Present.
And Chair Bott is absent. And those directors also present. We have Board Chair Taylor.
Present.
And Director Harrington.
Present.
You have a quorum.
Thank you, Madam Secretary. Thank you to Director Story for stepping in, and thank you to Chair Taylor and Director Harrington for participating today as well. The next regular meeting of the Quality and Patient Safety Committee is scheduled for Thursday, July 13th at 10:30 a.m. Has anyone registered to provide in-person or virtual oral testimony or submitted written testimony to be included into the record?
We didn't receive any registrations to provide oral testimony, nor did we receive any written testimony.
Okay, thank you, Madam Secretary. So we will now move to item number 3 on the agenda, report on quality and patient safety matters. As I understand, no action is needed for these items, only informational. And we will start with the HRO dashboard reviewed by Director Eric Makaitis, and he serves as the Chief Quality Officer for the system.
Good morning, directors.
Good morning.
So as always, we will start with the patient experience dashboard. Unfortunately, we did see a little bit of a dip this month, 77 down to 74%. We'll dive into some of the drivers of that in the next 2 slides. So if we go to the next slide, we have communication with nursing, which is one of our primary drivers, has been trending down the last few months. Now, we do have some action items in place. However, we went from 70 down to 63 month over month, April into May. Our largest drop was actually kind of attributed by the nurses explain in a way you understand. That was one of the drivers with the downward trend, as well as a decline in perception and hourly rounding and nurse leader visiting during the day. So we are doubling down on those action items in the A3. We have, we're working it into our daily management board as well for our medical surgical units to have a daily tally essentially of, our nurse leaders rounding on each patient every day and ensuring that our nurses, our attending nurses are performing commit to sit at the bedside so that they're spending time with the patient every day. And then the second contributing piece on the next slide is our environment of care. We did see a slight downtrend, just 1 percentage point, but it did contribute. And this was due to quietness of the environment that took kind of the biggest dip into this month. But again, relatively flat, so we're not really deploying any countermeasures yet on this measure, but we're going to keep a watchful eye on it. And if it continues in this trend, then we'll work with our EBS and environment partners to try to adjust. Any questions on the experience piece? If not, oh, yes, please.
Yeah, I have a question. I want to go back a slide. It's communication with nursing, and I see that it's been up and down and up and down and up and down. And so probably when it goes down, you do an intervention, and then it seems like, do you have plans that you can do something to sustain whatever gains you make?
So those daily management boards that I kind of mentioned in passing, that is going to provide visual management to the frontline staff, something that they can look at daily to make sure that those components are being done on a daily basis. So kind of red, yellow, green, are we on task or not for the various interventions. So it's something that we then as leaders can look at longitudinally, week by week, month by month to see how we're doing and whether or not we need to kind of reinforce that accountability to those interventions.
Dr. McKay, so you're not concerned about this downward trend then?
I mean, we are, so we're kind of doubling down again with it. Yeah.
You don't perceive it as being something that's of any significance?
No, I think it's something we are looking at, especially in the nursing domain, and it's something we're working with our nursing leaders to kind of deploy countermeasures and make sure that we're holding teams accountable to the tactics that we're trying to put in place.
So you haven't seen any structural or operational changes that would, well, that's not the slide, but
no,
the nursing go back.
Yeah. In terms of changes that would have driven
Staffing,
downward trend,
staffing,
not really. No, I think it's
environmental issues.
I think it's much more kind of that, are we doing the blocking and tackling on a day-to-day basis and being consistent? So.
And the only thing I would add is that we still, if you look at the ends at the bottom, this current month is usually a little bit lower because there's a few that are still to come in. So we'll see what everything gets posted in and where we wind up. We get nervous if it's either the lowest of the trend line or if it's something significant deviation, but there always is opportunities for improvement. So we'll keep monitoring to see how the month closes, and we'll look at it. We are looking at the trend and how far you get off of the trend line. So it's something that we definitely will be working with our team to note and look at what we can do to optimize and look at the processes that we have coming forward. But we'll also monitor the close of that month and see where it winds up, and then put in plans into effect. But one of the things I will say from our, just in case they can hear me, one of the things I will say that I do credit our nursing leadership team is they do have an ongoing performance plan that is year round. And so this just lets us know if there's certain areas that we need to look at. The other thing that is done after these scores that we share with the board is that we'll break them apart into individual units. And was there one unit over others that had a different issue, and then they concentrate on that unit for refresher education or touch points. So we definitely can do an in-depth look at the meeting coming forward with our nursing team to show how we resolve it. But they look at the data, they break it up by unit, they look at the area, and then they go back in and they review it. So we'll see how the month closes. We'll definitely, anytime we're off our mark, so I would say that we're not at the goal that we want to be, we'll keep doing the refreshments and the education and training and looking at the hot spots. So just for a point of education for the board, we can schedule a presentation to come up and nursing can look at how they actually use this on a day-to-day basis.
And I would add that the nursing director over Med-Surg has been really driving that rollout of those MDI boards. It's been a really good partnership and that daily management for the frontline teams. So, and it's been a process. Right now, we're not fully rolled out yet, and it's going to be something that I think is going to really help move the needle.
Well, the month of June will be interesting then.
Agreed. Okay, if no other questions, we can go to documentation. Thank you. So we did see a nice uptick in our surgical CMI for March. We went from 2.9 to 3.1. I'm happy to share that we've now met with all of our division leaders, thanks to Dr. Rich Keene and his division chairs. We have had meetings now with trauma, cardiothoracic surgery, general surgery, and vascular, as well as on the medical side with gastroenterology and oncology. And have engaged our ATOS partners to help do almost near real-time feedback. We have weekly meetings now where they audit 3 to 5 charts and are providing any identified opportunities to our trauma team. So as this work continues, we're hopeful to see a continued uptrend in the CMI for surgery. Next slide. So this is our observation percentage of all discharges. We are planning for next week, actually, the start of a value stream analysis that's going to look at beginning to end patient presentation to the emergency department all the way through to being seen in a clinic. So what all of those processes look like, mapping all of that out into a roadmap, and then kind of chunking that work out into smaller projects to start looking at those processes. This is a piece of that and how our interdisciplinary care rounds are contributing to those outcomes. So this should be a driver there between documentation and how we round on the patients daily. Next slide, please. Thanks, Debbie. So we've seen a very nice trend here on observed over expected mortality. So less than 1, it means that we are observing fewer mortalities than we're expecting. So it's both a documentation opportunity in terms of our clinicians getting credit for just how sick our some of our patients can be, but then also kind of tracking and trending the true mortalities. And I'm happy to share that in May we did our first full month of case reviews for mortalities, and that's acting essentially as a pre-filter to identify any opportunities and share that out to existing structures, whether it's departmental review, nursing review, hospital oversight, and so on. And I'm happy to share in May we didn't find any concerning trends. So next slide. So this one I'm very excited about. This is our trend for sepsis. And in the longitudinal data that I've been privy to since I think January 2021, March of 2023 represents our best month in that time frame, so about 2.5 years. We topped out at 68% compliance last month, and our rolling 12, you can see at the beginning, so rolling 12 in April of 22 was at 17%. That's now pulled up to 41% compliance for rolling 12-month average. A lot of intervention has gone into that. There was a rapid improvement event in December focused on sepsis in the emergency department. as well as a lot of inter-rater reliability in how we validate our sepsis abstraction, as well as a lot of education in how we're documenting and treating sepsis. Any questions on that one?
I just think that's awfully impressive.
Yeah, thank you. Yeah, the team's done wonderful stuff. Yeah, it's,
I mean, this,
yeah.
you just think about the consequences of not managing a patient, you know, who's, and from what I understand, this is something that starts in the ED, right?
The majority of cases, yes.
And the reason this is a special metric for our health system, it's for everybody, but more than most for us, is that delay of care is something that you often see for patients who have been underserved medically. And so being able to have a prompt and efficient sepsis program can mean a very big difference in the success of the patient and treatment. So I want to commend our quality department and our clinical department for the improvement that they're doing on that, and it does translate to real meaningful change for our patients.
Life. They're alive.
All right, next slide. So this is our hospital-acquired C. diff measure. You can see in 2022, we had 43 hospital-acquired cases. In 2023, year-to-date, this is through May, we've had 10 cases. So if we annualize that out, we're on track for 24. Again, this assumes a linear trend. You know, sometimes you can have a bad month or not, but, you know, if we assume a linear trend, we should be heading for 24 cases for 2023. So we'll continue to watch there. A lot of interventions in terms of early identification with the nursing team. There's a nursing protocol. I think that's why we're seeing this downward trend. Early testing. We get dinged when there's symptoms, and if we go beyond the 3rd calendar day, they may have come with the C. diff. However, we end up having to call it a hospital-acquired infection if it goes beyond that 3rd day. So a lot of process-driven performance here. So, next slide. We have a couple slides on readmissions. However, I will call out that we have our readmissions work group team to do a deep dive for all of you today on the work that they've been doing. But this is our house-wide readmission. Again, a very nice downward trend in the last 3 months, up from 12 down to 6.8 in February. 7-day readmissions remain in the low single digits. I think for February we were at 2.2%. Next slide. And this is EDAC, so excess days of acute care. So this is kind of raising the bar for the team. So the readmission slide looks at any inpatient readmission after within 30 days after an inpatient stay. This is looking at any acute care utilization. So ED and observation also counts for these. So we did see a nice little downward trend, 24 to 21 going into February. Again, a lot of tactics around that value stream analysis and how we are going to look at transitions of care, a lot of what the readmission team is probably going to touch on later. Next slide. We'll move to throughput. Again, another process-driven improvement here that really showed some nice improvements through the end of 2022. Again, this was putting a provider towards the front of the emergency department and expediting being seen by a physician that has dropped our left without being seen into the low single digits. So we're fluctuating between 1.4 and 3%, so right on goal. Next slide. And this is our ED median length of stay, and these are for patients discharging. We did see an uptick, and I'm attributing some of that to the increase in patients. We'll see in a couple of slides, we had about 200 additional discharges March into April, or April into May. So we have seen kind of an uptrend in patient volume. So I think that maybe has a bit of a contribution there. We are also planning in July a CT scanning process mapping with our trauma and our ED teams to kind of clarify how we streamline and become a little more efficient in how we're doing those the imaging that's been identified as a potential contributor and kind of slowing down the processes in the ED. Next slide. And Director Story, we added this as a follow-up from last month for you. You had asked about what about patients getting admitted. So this was decision to admit. So when an ED clinician, whoops, sorry about that. Let's try that again. So when an ED clinician makes the decision to admit the patient, what is that time in minutes to get them departing the ED? So we can see a slight upward trend into April. Again, I'm attributing a lot of that to the volumes that we've seen the increase in patient admission.
I didn't hear the last part, I'm sorry.
Sorry, we're attributing a lot of that uptick, much like the last slide. We had a lot more admissions going into the spring. So I think just with the extra volume, it's become a little harder to.
So you're working against the bolus injection of patients.
Right.
So it was one of good news, bad news story.
Yeah.
Yeah.
But two things are true.
Yeah, and you also have a little bit of training that happens in June and July. As you know, we're a teaching hospital, and so we have new residents that on board during that time, and so they're finding their way. But we will try to put in some additional programming to make sure that we can help them through that transition.
All right, so next slide, and this is our variance to geometric mean length of stay, relatively flat at 2.25 days. We have seen some operational improvements, though, early in the year with room turnover times dropping from 130 to 99 minutes. Additionally, more transporters were hired, and we've seen a nice decline in transport times, and from Q1 at about 57 minutes down into the mid-40s, moving into Q2. So a lot of wins there. We're hoping to start seeing an improvement to that variance. Next slide. Our last two slides are HEDIS. Again, kind of that slow march towards the goal. We see a nice positive trend here for our breast cancer screening. Some of our standouts in terms of clinics are Prieto, Blue Island, and Belmont that have respectively achieved scores of 87, 78, and 74%, with national averages in 2021 being somewhere from 51 to 71%, so performing very well there. Next slide. And hypertension, this is our blood pressure control measure. Again, so actually this one, every clinic improved from March into May. Current leaders are Cottage Grove and Austin, both north of 60% for their compliance. And just for reference, national averages in 2021 ranged from 50 to 70%. I think that's it. That's just there for reference, RE3s. There's no other questions. Yes.
I just had a question. Some of these measures are just Medicare population only, and some are, it's helpful to clarify that.
Of course.
Because, again, I was looking at some of the readmissions and the encounters. Are you getting them from nursing homes, or are they coming from home? There's sometimes a reason why you have some changes there.
Of course, yes, and so I can call that out moving forward. How we try to tweak these slides is how we report publicly, so what's driving our star rating and leapfrog and all of this, so we try to really kind of tweak those data slides to align with that. So.
Any other questions? Okay, thank you, Doctor.
Thank you.
Report. Let's move to item number 3B, regulatory and accreditation update, to be reviewed by Cynthia Fish, Director of Quality, Regulatory Affairs and Accreditation.
Thank you so much.
Sure.
Good morning, everyone.
Good morning.
Thank you. So the update I have to present today for June, at Providence Hospital, we continue to wait for our CAP survey. That is the laboratory survey. They're still due this year. In addition, we are still in our Joint Commission open window for the hospital survey. Most likely, looks like it may be towards the fall. In the meantime, we are doing random tracers throughout the hospital and looking at our vulnerabilities. We continue to also report on weekly the findings from the mock survey that we had with the corrective actions to ensure that we are in compliance. In addition, we are also looking at a gap analysis with the whole hospital manual to see where are the chapters with their compliance and meeting those standards overall. For Stroger Hospital, we are looking to host a mock survey here. Looking in the summer, it might get pushed back a little bit, but we are hoping to plan that here soon. And I am also meeting with the chapter owners to ensure where they are in the compliance from the last survey. So where are they currently? And then I'm happy to announce for the system overall, we are going to be looking to move forward to receiving applying for and receiving healthcare equity certification. So that is a new certification that opens up with the Joint Commission, actually July 1st. So very excited on that work. Any questions?
Two questions.
Sure.
First was, can you expound just a little bit on the equity certification?
Mm-hmm. You know, I'm looking forward to it opening in July 1st so I can see what those standards are, but it wants to ensure that organizations are providing, equitable care. Right now, I will say from January 2023, there are 7 standards that have been put into place for equity. They are leadership findings. So we already have had an analysis with Shannon Andrews, looking at where are we as an organization and meeting those. Mostly their leadership standards, and I can share those next time with you. They are being looked at when the surveyors go out, but they're not actually being scored. So this will actually expand, and I'm not sure, but it will probably be through nursing operations, all other operations of the organization, I imagine education, communication. But starting July 1st, that's when the actual certification opens up, and I can see what those standards are. And I'm happy to share with you.
And we can add a little bit about it, that we're very excited.
Mm-hmm.
Actually, Cook County Health was selected as one of the partners in helping to pioneer what equity would look like with the Joint Commission. We have special presentations that were done between Cook County Health and the Joint Commission and looking at those standards. While we are waiting for the full window to open up, a lot of the standards go that we actually have things in place that look at comparable metrics and outcomes, especially in areas like the mortality and morbidity of expectant mothers. What we look at on outcomes, on key indicators and key diagnoses of chronic conditions where there are disparities, and what we're looking at to address them. And here at Cook County Health, we have a series of charters that Shannon Andrews is our Chief Equity Officer, looks at and works with Dr. Fegan, with Dr. Irons, with Dr. Collins of the different committees, and across the spectrum with the providers to look at what we're doing to implement strategies. So that's why we believe that hopefully when it comes out, we would be well positioned to apply as a center of excellence for equity and inclusion in the clinical space, given the work that we've done in visiting with the Joint Commission and talking about how equity can be achieved, in showcasing our charters and what has been done, and working with even the Illinois Hospital Association and helping to develop that work. And so we're excited. We'll see where this goes, and we hopefully are showing what a clinical system driving equity would look like in our country.
Well, I appreciate that explanation here, because you anticipated what my question was going, given what's been over the last 2 or 3 months in the news in terms of Black women and that the death rate amongst Black women who are in childbearing age, for the young lady in Florida, 8 months pregnant. So that's why the question. So I'm glad that we're already ahead of the game, in essence. What you said, that you already have a program in place to focusing in on that population, that cohort of women.
And don't want to steal the thunder, but I know that that Dr. Abrego from our OBGYN department and Dr. Hasbrook have been working on a presentation to showcase what they're doing. And one of the benefits of being an integrated system at Cook County Health is we can approach it from different sides. So even on the mortality, morbidity reduction of expectant mothers, we can do public campaigns, because one of the key issues is high blood pressure, which leads to preeclampsia. You also have sepsis, and then you have postpartum conditions. And so what we can do to inform, like we do a stroke, you can tell people you have a drooping face, here's what you do, make it easy to understand what are the symptoms. We can do that in education, pre and post-term delivery of children. And then here clinically, we have things that we are working on and best practice from like the California model on what they have done in hemorrhage and being able to do avoidance in clinical practice. So they'll be having some amazing presentations come forward, and we can make sure it's presented also to the quality committee, because they're doing some amazing work in that space and helping to bring down that disparity.
That's great.
Yeah.
Once again, taking the lead on a very critical and important initiative.
Mm-hmm. Yeah, I just want to make people aware that the Illinois Department of Public Health has a task force on infant and maternal mortality, specifically focused on African Americans. And they do meet regularly, and if we come up with something, I'm sure they'd be very interested in hearing about it.
Thank you for that information.
Any other questions? All right, thank you, Cynthia.
Thank you.
Great report, thanks. Okay, let's move to item 3C, the American College of Surgeons National Surgical Quality Improvement Program, Year 8. Update to be reviewed by Dr. Mark Willey, Dr. Richard Keene, and Brussi Ragisi.
Good morning, directors.
Good morning.
Thanks for listening to our work here. I know a number of you have seen some of this material over the years. I appreciate your attention. I will review this quickly, and please stop me if I'm moving too quickly through some of the background. So, as most of you know, ACS NISQIP is a validated, risk-adjusted, outcomes-based program to help us improve the quality of our surgical care. The program was built by surgeons for surgeons, and the participating hospitals have a number of tools at their disposal to help improve the quality of surgical care, providing risk-adjusted reports. And there have been a number of studies that have validated the use of this program. Next slide, please. So what we'll be reviewing and what we use to make decisions are risk-adjusted benchmark reports that are basically benchmarking what we do against about 700 other hospitals. We have access to real-time reports, which can help us identify problem areas in real time. And then NSQIP also has national conferences and collaborative meetings that help us interpret our results and make changes. There are a number of best practice tools that are available to us. We participate in Hospital Compare, which is a CMS program that allows voluntary reporting. The ability to participate in Hospital Compare is one of the benefits. And then there are a number of data validation and audits that ensure compliance to data standards. Next slide, please. Originated in the VA in 1991 and has been increasing in participation in a number of hospitals throughout the past couple of decades. We joined in 2014 and presented our original semi-annual report to you in 2015. Next slide. Next slide. Just a schematic of the different hospitals and the scope. It's mostly U.S. hospitals. There are general vascular and subsurgery areas. We have target cases, so we can potentially target any type of case that is done at the hospital. Uses clinical data, that's one benefit. This is not administrative data that we're looking at. We look at 30-day data. It's highly standardized, so we know that every definition is being applied in the same way to any patient in the program. It's standardized. And then there's a trained abstractor that's doing all of the abstraction. And we have a full-time person doing this. And reports are generated by the NSQIP team, and then they send us a report every 6 months. Next slide. Very briefly, I just want to summarize by saying we don't abstract every case that's done a Stroger. Certainly it's not enough manpower to do that. We are moving from 30 cases every 8-day cycle to 40 cases, and this is probably, 15% of what we're doing at the institution. Next slide. We get preoperative data, demographics, labs, surgical profile, all the clinical variables, complications. Again, it goes out to 30 days. Our abstractor even calls patients to fill in the gaps. And then we can also create custom variables to look at areas of interest. Again, all specialties are represented. You can see on the left-hand side, numerous types of complications are looked at. Next slide, please. And then these are the current cases that we're targeting. So we'll occasionally go from case type to case type to really drill down and abstract every single case that's done in that area where we have time to increase our numbers, improve the statistical modeling, and if there's nothing to report, then we move on to the next one. Next slide. Next slide. Just summarizing the types of data that are available. In terms of results, there are exemplary is applied if we're in the first quintile. Needs improvement is if we're in the fourth quartile is what I meant to say. Needs improvement is if we're in the lowest quartile. Also, if we're a statistical outlier, we would be assigned either exemplary or needs improvement. And what I'll be presenting is really odds ratios. Next slide. So an odds ratio, I just want to draw your attention to the very bottom there. The definition essentially means what is the likelihood that an outcome is going to happen at our hospital relative to all of the NSQIP hospitals. And if it's above 1, then that means it's more likely to happen at our institution. If it's below 1, then that's more likely, it's less likely to happen at our institution. Next slide, please. Just a little bit about our team. We joined in 2014. It was initially part of a Blue Cross partnership, and the team consists of myself and Blessy Varghese, who's sitting behind me right here. We look at 30 cases over 8 days. That's increasing to 40 shortly. And like I said, we get a semi-annual report every 6 months. It contains 12 months worth of data. It's benchmarked against other NICU group hospitals. Like I said, it's risk adjusted. Next slide. So this was the first project that we tackled, I think somewhat naively maybe, but I think our results, naive in the scope that we thought it would take, it actually ended up, we generated a multidisciplinary team that really tackled this problem very well. I think all of the data, the proof is in the pudding. Surgical site infections are the second most common type of healthcare infection. It's very common, it's very costly. Patients are more likely to be readmitted, spend time in the ICU, and die after surgery. Next slide. So our initial reports revealed an occurrence near about 1.5 times the rate of the average NICU group hospital. Like I said, we assembled a multidisciplinary team, came up with a treatment bundle, and that gray arrow shows where our stage implementation began. And our most recent semi-annual report shows that we have less than a 1 odds ratio. So we've had some sustained improvement. Certainly you can see that there was a change a couple of years back. Certainly highlights the need for continual education, and you know, it's a continuous process. Next slide. Just briefly, there's a bundle that we put together that has been used at other institutions. Next slide. There was a return on investment calculation that was provided to us. Unfortunately, ISQUIC, the Illinois Surgical Quality Collaborative, did not provide these data to us most recently, so this is several years back, but they compared a report of what our post-implementation to our pre-implementation looked like, and estimated cost per complication, and told us, essentially did a calculation on what our financial savings were. Next slide. So our baseline rate was about 2.8%. Our post-intervention rate was 1.1%. And essentially, if you estimated a cost per complication of $2,500, the savings annually was nearly $250,000. Next slide. There's another project that we spent a lot of time working on and are continuing to work on. It essentially looks at patients who are having colon surgery. I presented these data previously, who essentially have a slow return of bowel function after surgery. So it can increase the length of stay. Patients get reoperated on. They can have to decline their functional status. They have pain and discomfort. There are lung complications that can happen, and it's costly. Next slide. So our initial reports showed that we were 2 times the rate of the average hospital. Again, we came up with a multidisciplinary team. The gray arrow is where we staged our implementation. And we have had some wins in this area. We've also had some challenges. Again, it requires not only involvement from surgeons, but also anesthesia, floor nursing, education, so on and so forth. So this is something we continue to work with our colorectal surgeons and other team. Next slide. The colectomy length of stay also can be affected by this, and I'd like to report that despite having an increased recovery of bowel function, our length of stay has generally been close to the average in this group hospital. There was, I'm sorry, I'll make more comments. Some of the rises you see here in these years here are coinciding to COVID. They were doing less elective surgery, more emergent surgery, and those patients have a longer recovery as well. Next slide. This was just the bundle we put together that I previously presented. Next slide. In terms of the return on investment for this this outcome, there was a relative change in rates of about 30% after we implemented the bundle. Looking at about a $10,000 cost per complication, the savings were about $350,000. So this is certainly a high impact area for us to focus our efforts on. Next slide. Just to give some scope of the cost of what it cost us to participate in the program. The clinical review is $100,000. There's an annual fee for NSQIP, and that's $25,000. So hopefully we're paying for ourselves. Next slide. This is a new outcome that's come up recently, and I think what we've learned, having done this for now 8 or so years, is documentation is very important. I'm sure you hear about that all of the time. So this is an outcome during thyroid surgery. There's a nerve that runs near the thyroid that can be injured during the surgery, and the symptoms include airway obstruction, which is the most severe, or hoarseness. That would be the most common complication. Our odds ratio was around 1. We started abstracting every thyroid, but you can see over the last couple of semi-annual reports, the most recent odds ratio was 2.5. So we have reviewed cases with the thyroid surgeons. Certainly it turns out that documentation, it looks like there needs to be some changes to how the surgeons and staff are documenting this after surgery, and we're looking forward to seeing how that changes our outcome here. Next slide.
So, excuse me, so you're saying this is more documentation as opposed to practice?
I mean, we can't say that for sure, but certainly it seemed like that was some of the low-hanging fruit. Providers may be documenting hoarseness when it wasn't necessarily clinically there, or it was present before surgery. And so if it was present before surgery, it wasn't necessarily a complication. So we're looking into this a little bit more carefully, but we can't say for sure. This is the slide I always like to leave with. This is all cases, morbidity, meaning all complications since we joined the program in 2014, and it's just a fun line to follow. You know, we have enjoyed significant improvement relative to other NSQIP hospitals. I'll make the point that all other hospitals are doing their best to get better in this program as well, right? So it should be harder for us to do better, but we still are. So I'm very proud of the team, all of the Department of Surgery, Dr. Keene and his support for this program, and all of you as well. Next slide. So in summary, NSQIP utilizes clinically rigorous data abstraction methods. We've several opportunities for improvement. We have ongoing projects that have proven results. We're improving patient care, decreasing costs, and I believe it's a worthwhile return on investment. And then the rest of your slides are the actual full semi-annual report from the last 5 years. Yes, sir.
Yeah, I noticed in slides 16, 21, and 22 that there was a peak that occurred just after COVID, and you did mention COVID. What was the relationship between that and that jump in those numbers?
Yeah, it's a great question. It's hard to say. I think, you know, we like to blame COVID for a lot of things, and, you know, certainly I use that as an explanation. I think for the surgical site infections, we identified that, you know, certain parts of the bundle were not necessarily being practiced by all practitioners. Surgeons come and go, nurses come and go, you know, agency nursing, and so on and so forth. So it was, I think, some re-education took place, at least for this project, and I think that, you know, probably explains it, although we can't say for sure. And then as far as, you know, the colon surgery, the colorectal surgeons did believe that, you know, we certainly were doing more emergency cases. We stopped doing as much elective surgery, and the emergency cases tend to come in sicker, having more derangements medically, as well as they come in obstructed, the emergency cases. So that would explain why their bowels didn't really wake up as fast after surgery as well. So I think that makes sense.
Thank you.
Do you think there will be the time when you, when this gets automated so that it's representative of all cases, not somebody having to hand enter the information?
Yeah, I mean, that would be an ideal future state. I think investments in, this is just my personal opinion, investments in, artificial intelligence and such might, play a role at some point in the future. That's a really good point.
Okay. And then the next question was, the types of complications. Do you compare the data for all the cases to ensure that you have good sampling? Because again, sometimes the complications really affect patients as well, the outcome.
Yeah, are you asking about how the percentage of cases that we're doing versus
Right.
what we're actually looking at? Yeah, that's a valid point. I guess that's why we rely a little bit on the, NISQIP to do the proper statistical modeling. Statistics can only tell you so much, right? Especially if you have a low sample. I think that's why we're always advocating for additional funding, to have, more clinical reviewers who could potentially increase the percentage of cases that we're actually looking at. But it's a very laborious process.
Oh, I know.
As you know,
it is.
yeah.
Yes.
Yeah.
Thank you.
And I would just add, we do utilize two prongs of approach for monitoring. So the statistical analysis and the wonderful work that they're doing with NSQIP, which is really helps you improve in the aggregate over time, even though it's doing sampling and extraction. But whenever there is a case complication, anything that is more significant, the individual departments review it. We have individual review of the departments. We have, of course, focus review. We have adverse events. So we have a series of events whenever any case deviates significantly. So, but the goal of an SQIP is to let you know what you're doing every day and the little things that you can improve, or maybe not the little, but the like training in this area, providing refreshers in this area, doing this and looking at every case over time through a sampled review. And so we do, but I do want to let you know, we do look at the big cases. We look at any adverse events, something that deviates any cases to make sure that every case is getting attention.
So you have an adverse event reporting system? Yeah. Okay.
Adverse event reporting system, we have departmental reporting systems, we have reviews. So we have many different, depending on the level and severity of the incident that is available.
Okay. Thank you.
Yeah, thank you for clarifying that. Yeah, we absolutely look at every complication that happens at the hospital, for sure. Yeah. Thank you.
Great. Any other questions?
Just a quick one. Sure. Going back to the thyroidectomy, when would you make a decision to develop a bundle?
That's a really great question. The funny thing is, early on with the surgical site infection, I think we pulled the trigger. I mean, we were right in retrospect, because it was a true thing. It's experts who work in this area. This is a question I've asked at some of the conferences, and they would say after one semi-annual report, they wouldn't typically pull the trigger. Usually, you're not looking at every single case, and so there is some statistical, the modeling sometimes pulls events out that wouldn't necessarily be called significant clinically. But after 2 or 3 semi-annual reports, if it continues to be an outlier, that is something that is real. And certainly with the thyroids, because now we're looking at every thyroid, I think it's no longer like a 30,000-foot view. We're actually looking, at least through the program, we're looking very carefully at that. So I would say this is something that if the documentation changes don't make the effect that we want, then there's going to be a much more close, we're going to be looking at this a little bit more closely to change actual clinical practice, I would say. So probably within the next 6 to 12 months.
Okay, that sense of, it would, once again, as you said, I'm not putting words in, I heard what you said, the urgency with any deviation would determine going forward the next 6 to 12 months.
Yeah, I would like to see another semi-annual report. We can also run live reports, so that's something I'm planning to do in October, because we met with the surgeons, 6 months prior to that. So I wanted at least 6 months of data, and we'll run a real-time report and make sure that, we're not seeing this go in the wrong direction. So, yeah, so in 6 months, in October, we're planning to meet with the surgeons again with the live data.
Because once again, just like with the looking at all adverse reactions?
Yep, correct. Thank you.
No, thank you.
Dr. Ray, thank you. Congratulations on clear improvements and sustainable improvements. Thank you. Okay, we'll move to item 3D, which is the update from the HRO work group on admissions to reviewed by Dr. Umar Chabar and Diane Creel.
Thank you. Good morning to the directors.
Good morning.
Morning.
Good morning.
Looking at our 30-day readmission rates year over year, last year was our best year yet at 9.73%. And we're really happy to report, you know, with there's a lot of leadership changes this year, a lot of alignment across the care continuum. With we missed the first title slide, but we have a new co-chair with me, Diane Creel, who's you want to introduce yourself?
Oh, sorry. Good morning. Diane Creel, Director of Complex Care Coordination and the Transition of Care Team.
And I'm continuing on in this work as a hospitalist, a co-leader of this group. So next slide, please. You can go on. One more, please. Our readmissions work is really guided by this graph, which lays out which are the conditions we see in high volume, but also which are the ones that have higher than other hospital readmission rates. So the first three conditions on the left represent the highest volume, so heart failure, sepsis, cirrhosis. And then there are other conditions that we again see more than higher readmission rates, such as renal failure. And then oncology is also in here. It's really a service line, which we don't have a service line, but if you think about cancer patients, they're represented in many of these diagnoses, and that's another higher than other hospital readmission rate for us. So this is really our guiding light on where we need to focus our efforts to make sure that we improve upon our readmission rate. Yes.
And those areas where we're over, does that representative of the population we serve?
Absolutely, right. So our highest volume again is heart failure. A lot of the patients overlap as well. So a lot of our patients have heart failure, but they also have renal failure as well. And that's you know, volume overload is one of the highest reasons why patients come in.
With the renal failure, are those patients that are on dialysis or just develop advancing in their disease?
The majority that are preventable, I would say, are very close to the dialysis. A lot of and even the ones that, you know, so I think, you know, there's about a third, when we looked at this, a third have acute renal failure, but then they go back to normal kidney function, and about 2/3 have some sort of chronic kidney disease. And, you know, I think the areas of opportunity are really the ones that are more advanced along.
And I think the area of opportunity, because this is one that in Chicago area is so disproportionately in the Black community, in the low-income communities, and if public health and everyone can get together, it would be ideal because, again, this is one that is treatable if caught early, and the survival rate can be high then.
Absolutely. I think, you know, this is really a, you know, population level, you know, issue, right, in terms of diabetes and hypertension control. So we're in the weeds right now, but, you know, I wish we,
And I just want to clarify, it's really related to socioeconomics, and the highest poverty rates are among Blacks and Hispanics.
Right.
So that's,
Oh, yeah.
that's what's really driving this.
Mm-hmm.
absolutely. So we, you know, we touch on some of those aspects as well, the SDOH issue. Next slide.
Can I just piggyback on this discussion in terms of, let me reach back about the bundle concept. Now, if I'm reaching too far, then you all stop me, but in terms of this patient management of this patient population, Am I going too far by implying that there's a bundle in the future relative to this patient population?
For the, kidney failure?
Yes.
So that's a group that we've started to take on this year. It's really a newer group that's in place. But we're trying to do some of the same, we know some of the successful tactics for our heart failure patients that we worked on. COPD is a little bit more advanced in that work. So renal failure is a newer condition that we've taken on this year. And, we're doing a bundle in a way that, we know that, okay, getting them follow-up, getting them a post-discharge call, supporting them in their disease, self-education, and also addressing some of the STOH components. So, if they're struggling with food insecurity, housing, helping. So, we are in the middle of, doing a bundle for this patient population.
Yeah, I think we all recognize that this was, Director Harrison, is more complicated because of the social factors and blending, that intersection between the social factors, i.e., and then the clinical issues. And that intersection makes this seem like a bigger bundle.
Absolutely. We have a slide later as well that will talk about this patient population, what we're specifically focusing on for this.
The element for renal failure, it's not technically a bundle, but I know that they're working is looking at what indicators present when you have the patient in the health system or in an inpatient admission, because often there are other things that are treated, and maybe there was an indicator that could have been caused or something that can be looked at. That's why artificial intelligence is really looking in this space, because they can say it could be missed, but there were these three things that individually do not present an issue, but collectively do. And so you could get that patient in treatment. What could we do to have prevented them having an acute renal failure outside the system when they were here? And so that's an evolving place of care. And as we said, we do see a higher propensity with diabetes, which is going to give you a higher propensity of renal failure patients. But what we can do, and I know the team is working on, is creating some processes that would help us to identify those. And hopefully that's some area that AI and machine learning can help us in the future. But I know that they're working pretty diligently with our nephrology department to try to figure out what we can identify faster to be able to avoid the renal failure readmission.
And I think that's the key, is many times people don't have the tests performed. And I know it was a battle with some of the commercial insurers in trying to get it performed. So I do think that it could really make a huge difference by early testing and continuous, especially for target populations that maybe have diabetes or other conditions. Great.
And I think the excellence in the comparison that we also miss is that commend the team, because sometimes we think we're doing well, but it's when you compare to others that you see we could do a little bit better. And so, in the equity work, you look at the comparisons that let you say we need to focus in better, because even though we do have more patients and more chronic conditions, we need to do better to address it. So we will take the challenge, and the team's working on it diligently, and excited about the opportunity of what we can come forward.
So can I just make a statement that I'm encouraged, Dr. Willie, your comment about AI and the opportunity, Angela, maybe do that crosswalk in terms of this, when we talk about the future state and a bundle, is the role of AI in the work that you all are doing. I would advocate financial support for that initiative, because I think it would obviously accelerate whether we wait 6 months or 12 months. I don't know. I don't want to go too far once again, so you can cut my mic off. Y'all can just turn my mic off. I've been watching too much TV.
Just for those who can't hear her, because she's in the background, our CIO and Angela said that we can do a lot with financial support.
Yes, we have a number of AI initiatives underway, and this definitely fits in that.
I'm glad this is recorded. But to that end, our leadership has supported our work in this space as well. We're looking, and Cerner has a module built into our EHR that incorporates machine learning, and being more proactive in the space. So we're exploring purchasing that so that we can be even more diligent about capturing things before they get out of hand. So looking at our key focus areas for 2023 and 2024, there's three major areas. One is our high utilizers. These are patients who have high returns to the hospital. They contribute to our excess days. They are high cost to our health system, and a lot of those patients are, they really need engagement in lower cost of care settings. That's an opportunity area. And then utilizing that graph previously, again, into the specific high volume conditions that we know are ambulatory sensitive. We get them plugged in to our health system, then we know that we can prevent those readmissions. And then there are general processes that benefit all our patients, which is particularly that post-hospital appointment process to make sure that once they are, so that they transition appropriately to a usual site of care. Next slide. Looking at our high utilizing patient population, this is something, again, we've started a little bit more in depth looking at this patient population. They really break down to we broke it down to three different groups, but the overall theme is that largely they are insured and largely they are not connected to a usual site of care. And that increases as their utilization increases. That super utilizer patient population that constitutes 5% of these patients, they're largely insured and 46% have PCP. And we chose the definition of high utilization as 3 ED visits and 1 inpatient hospitalization. This looked at it for the 6 months. And again, we're looking even more granularly at what's bringing these patients in, but this is our preliminary analysis so far.
Can I just ask, this is very impressive, and I'm gonna say this because I may be telling my age here, but years ago when I got in this business, we just talked about frequent flyers, but we weren't doing anything about it. So this is quite impressive, the work that you all are doing here, and I just think it needs to be called out. This is good work, and I hope that if I can go take some liberties here, that you have this information, Neil, so it gives you an opportunity to touch those individuals from a practical perspective. So I applaud you all for this in terms of enhancing the quality of services that you all provide to our patients here. This is a real plus.
Yeah,
Congratulations.
and I want to piggyback on what Director Story said, because you can't manage what you don't measure. And so we're measuring things, and so now we can gain some type of control. But my question is, the people with no primary care provider, what do we do when we have someone that comes in, has an issue, and how do we connect them to a service?
So, Diane Creel, so what we're doing, now that we've got the data, you're right, it gives us an opportunity to identify interventions for the various things that we're seeing. For those with no PCP, I'll be honest, I was a little surprised. That's a high number. And so because I have a team of nurses, social workers, and community health workers who are more community-based and payer agnostic, but they're also kind of tied to the ACHN clinics, right? We manage about 50,000 of the ACHN patients, the county care patients, and they're largely tied to the clinic. So I'm able to, and what we did already is identify those patients, gave them to our team, actually the community resource navigators or community health workers, and told them to reach out, connect with the patient, get them engaged, get them assigned to a PCP. So we'll be measuring that to see if that indeed did happen. And then certainly when they do that, they're able to connect with them and enroll them in care coordination.
Yeah, it would be interesting to look at that data at some point, because we can assume that it would make a difference in a person's health moving forward, but it'd be exciting to see how many people that didn't have a primary care provider actually, as a result of some incident, now has a primary care provider moving forward, is less likely to wind up back here.
Right. Did that factor into their high utilization?
So go ahead.
So there is a program that we're looking at implementing, even more broadly, is that once you identify a high utilizer, you can create a flag in the EMR, so that when they come into the ED, you can make sure that they get assigned a visit with a primary care provider within our system. And so that's a process that we're looking to roll up. It's called high-risk medical home management. So you put in flags on patients that are at high risk or different elements, and then they get referred into a high-risk medical home management program. That's something that I know Dr. Collins and on the managed care side, as well as Dr. Irons and the medical team have been working to get started and roll out and implement. So hopefully we'll have some exciting updates as we continue those rollouts. But it sounds simple. Getting the flags on the right people and getting them to come in takes a little bit of work with some patient stratification. But and we also have Dr. Trick who's working with them on that. So I know our ambulatory care team is working to try to pair that where they don't have that, working with the ED, looking at the pathology, the partners, and getting that program started. So hopefully over the next few months, that's something in development. And I know it often sounds simple, but sometimes simple things can be very effective. So we'll see if that can help.
Israel, I thought you were just gonna say that that's an AI initiative. Somebody in the mountains in Utah somewhere, 30,000, can just go and just tweak this. And so, thank you once again, Angela, for your.
Unfortunately, Angela will be involved in the system, but it does take clinical expertise. So AI can't do everything. Our providers have to help find out those.
See, that's why I keep saying I need to stop talking, because I think it's rather simplistic, and I know this is great work, Dr. Willie and Dr. that you all are doing. So I don't want to oversimplify this, but I think that if there's an opportunity to augment your great work through AI, I would, once again, we're recording this. I would support that from the board's perspective.
And that was going to be my exact comment, that we have two projects sort of in place right now that proactively reaching out to the patients who have historically met this definition of high utilizers and getting them plugged into a medical home before they even hit our emergency room, but also a prospective program that if they hit our emergency room or our inpatient setting, then we get them plugged in. So both avenues, I think, are going to be fruitful.
Thank you. Before you move on, first I want to say I share my colleagues' sentiments on the great work that's being done. And as a follow-up to Director Harrington's question, understanding that it is the patient's choice who they elect to have as their PCP. So are you tracking the percentage of those patients that stay or that elect to come into our system, the county system? And overall, how many of them end up selecting a PCP? What percentage, I should say?
So I can speak to that. What we can tell is how many, as you know, how many were able to engage. I'm sure there's the churn, the churn numbers. We can already tell the churn in county care. We see it every 2 weeks. We see that churn. I think we'd have to go to our data analytics team, Amanda Grasso's team, to really get detailed information on what that churn looks like or that loss.
Sure.
Or gain.
And we can add, the program is, as we said, in development, the way that it would work internally is that if they do not have a PCP and they're using our services, we will engage them with the PCP that we have within our ability and network and make sure that they get seen. That's the beauty of the high-risk medical home, is that it's not just a home, it actually has pathway. So once someone gets in, they've been risk stratified, and there is some AI in there that you can use to look at the risk stratifications, what are their conditions, and then they would say this is a priority patient who could have a high readmission or could have something significant happen. And so then when it goes into the PCP for Q, they're also seen as a high-risk patient to get in immediately, and then they work in with our care team to do follow-up. So it's a comprehensive process that's being rolled out. And so it would work with our PCPs, and then if there was a fail rate, now you know that there's something that goes in there, and there's a registry that monitors that. So a lot of things need to come together, but the way the program works is that you first risk stratify them. They're identified as patients who need immediate, more specialized attention and handling. Then they're assigned, if they do not have a PCP is put in, and then they work in a partnership. And I know that, I don't know if Dr. Fegan wants to add anything as well, but I saw you peeking over this. We had presentations on this, and it's something we're very excited about that's in development and coming forward, but I think it could do some tremendous good. So we're excited to be talking about it.
Yeah, I hope that
folks have an understanding that these are patients who have traditionally not had PCPs. And that when we have these patients in the hospital, we give them an appointment to see someone immediately following discharge. And those are with primary care providers. And the key is trying to build rapport with these patients so that they feel the need to come back even when they feel okay. And that's a culture shift that doesn't always come. If for generations, I might say, we have patients who have sought their care in the emergency department, and that's the way they were brought up. That's how they were acculturated to interact with the healthcare delivery system. And the notion of a PCP is difficult. It's about building rapport with the patient so that they feel they're willing to come even when they feel well to try to do preventive services. So it's an ongoing effort, and it's not just putting them in front of someone, it's someone who they feel connected to. So that's always our mission. And I think that one of the things that we try to do with ACHN is sometimes we're more successful, even though we can give them an appointment tomorrow with someone here at the hospital, that if we can give them an appointment with someone in the neighborhood where they live, they're more likely to maintain that relationship. And so it's looking at not just the patient and their problems, but their zip code and what resources do we have close to where they are.
And so you heard the adage, it takes a village. So the village is first identifying the patients that need the help, finding where they are, flagging them for activity, creating a team that will follow up and monitor them to make sure they get in, and to look at the fail rates and then have more additional resources. But then also letting the clinic know for pathwaying that this is a patient that has a high risk and we have to try to accommodate to get in as quickly as possible, their elements that are reviewed, and how people are progressing. So it's a comprehensive system that's being developed, but we have high hopes that it will help us to get even better to that next level.
Well, yeah, sure. It just seems like it's all a lot of information to assimilate.
Yeah.
And like I said, at the front end, the behavior piece, getting people to become acculturated. And I guess that's why I go back to AI. And I'm going to keep saying that. See, y'all chased me out here. That I feel like it will add to the great work that y'all are doing.
Mm-hmm.
Yeah, I want to make a statement. It's really for the lay people that may be watching this. One of the things that people don't really understand is a lot of things are asymptomatic. Hypertension is a big example. There are no symptoms of hypertension. And a cardiologist I worked with years ago said there are only 3 symptoms of high blood pressure: heart attack, stroke, and kidney failure. Those are the symptoms. Those are end diseases. And so having a primary care physician is critical to establishing whether or not you're healthy. You don't know just because you feel healthy that you're healthy. You know, a doctor can help you understand that, and if you see a primary care physician regularly, they will know if you're at risk for hypertension, if you're at risk for diabetes, and it can prevent some of the things that we're talking about today. So this is really more for the lay public. They need to understand you may feel good, you may feel healthy, but you may not be healthy. And having and being in a system of care reduces the likelihood that you would die prematurely.
Thank you. Thank you, Director Irvington.
May
Please
I
continue.
just add one comment to support Dr. Vegan's discussion and talk about the community? Literature shows that it's best to hire within the community. You need to know the community well, and obviously we have an EPO plan that we're compliant with, but what we've done with the care coordination team, which is community-based, we've actually mapped their zip code, put it in the system to the nearest ACHN clinics. So they are as close to the community within that community as possible, again, while still being compliant with the EPO code or EPO plan. So that's not lost on us. That's a significant factor in connecting with the patients.
I'll speak to some of the data. I think that will help and answer some of the questions that came up. Next slide.
So what we've really worked on is focusing on who, the high utilizers are. We know disease states, we know numbers, but they're people. Who are they? And how do we engage them? So the first thing we did, as we mentioned earlier, is we divvied up the high utilizers into 2 cohorts. The first is the spreadsheet that that first population, or that first sample size, excuse me, that we grabbed, and we gave those who did not have a PCP to our CRNs on the team and said, please engage in care. But the other thing we did is we assigned the remaining folks to our nurses or social workers, again, based on whether it was primarily medical or behavioral diagnoses. And then, as Dr. Jabbar indicated, if we stay with that definition of 3 ED visits plus 1 inpatient stay within 6 months, you're going to have a rolling population, right? So every day, the list should theoretically change. So we have it in one of our systems where we're able to actually identify that. If they're admitted, discharged, or transferred, then we're notified, and our transition of care team, which is a team of nurses on the inpatient side, are assigned to work with them. So that's one initiative, but the other is disease-specific. As Dr. Jabbar said, we've got a really robust congestive heart failure and even a COPD program, so more disease-specific. We're working on the chronic kidney disease and oncology, more in development and secondary, and always, you know, when people say payer agnostic, what that means is we don't care. You hit the door, and we just need to identify what you need. So that's Medicare, that's other MCOs. So if you look at the first slide where we said 88 to 96% of our high utilizers, and there are, was it 5, close to 5 ED visits for every patient in that cohort, that's significant. So we, different strategies for each. So uninsured and CareLink, certainly we work with them, as well as we have the Cook Medical Group. And again, we have a subset of the county care population. We have about 50,000 of their total population, and every MCO needs to have some level of care coordination. So we're very familiar with the state requirements. We're following all that, et cetera, for all the MCOs. Next slide, please.
Can I just ask one question? Sure. And what percent of the population in your high utilizers are coming from home versus another location?
For the initial subset, or for the initial sample of
yes, for the high utilizers.
We don't have that breakdown, actually. As you say that, we don't have that breakdown, whether they're transfers versus coming from home. I would argue that the majority are coming from home, but I'd have to look at that data, especially if they're ED, because we factored in observation as well. But we can certainly get that.
You know, pending the age population, are they coming from a nursing home? Are they coming from a transfer? You know, what exactly? And that should be, you could probably connect it with the claims data. Right. Because the claims data was.
The vast majority are coming from home.
Okay.
So, thank you. This slide speaks to what Dr. Jabbar was saying. You can't work with patients unless you connect the dots, right? Mm-hmm. So our goal is, if you hit our hospital, our system, or anywhere, we're grabbing your hand and we're helping you through this navigation of care. So working with readmission and the high utilizer and the post-discharge, right? That whole circle of care, the 3 committees work very closely together, and that's what that represents. Next slide. So initial plan, what we've done thus far, data, you know, data gives us the opportunity to ask more questions, and so data-driven decisions. We actually formed a high utilizer subcommittee, worked with ER leadership, because, gosh, if we have, for that small group, if we have 5 visits for every patient, we need to understand what the issues are at a root cause level and develop some strategies. So we have ER leadership as co-chair. Not surprisingly, I guess, the majority, 81% of our high utilizers are unassigned and or coming from GMC or SANG stack. So I've modeled the complex care coordination staffing, which again are the nurses, social workers, and CRNs. They work as a team, a triad, right? So I've modeled it so that change the staffing to support those clinics that have the higher volume, right? So let's make sure we're connecting. We're not just uniform across all clinics. Let's customize the staffing to ensure we're capturing these folks and working with them. And again, CRNs working to schedule unassigned members to providers. We already have a contract with Legal Aid Chicago. They're a great partner, and we use them often. So between Legal Aid Chicago, Home Health Agency that I meet with regularly, transportation, et cetera, we have interdisciplinary care team meetings, and those social determinants of health are addressed. I'd like to get them a little bit more formalized, but work in progress. And then the TOC team, the transition of care team, have been reassigned based on data as well as the focus that we've identified. We've also, we've identified that a number of these high utilizers are insured. So a different strategy is we want to make sure we have a great relationship with the other MCOs as well. Everyone finds value in working with Cook County Health. And so hopefully mid-July, what we're going to have is a meeting between the care coordination leadership within the 3 MCOs we've identified to be able to ensure that if you're not with county care and you're with Meridian, that you need to make sure that you're connected to Meridian and Meridian's care. Right now, it's 1-800 call the customer service, et cetera. We need to track, trend, ensure that that patient isn't lost. And then again, focus on the identified populations and the virtual urgent care that will be, I believe, at the end of July. The goal is to go live with virtual urgent care. We've been working with the consultants on that because there's 2 aspects of where we're involved. Number one, there are individuals who are referred to virtual urgent care who don't need that necessarily, that level of care. They will be referred to our team. But conversely, if we have someone who's discharged and needs to see their provider in 14 days, but doesn't, has complications before then and can't get to their provider, we have the virtual urgent care model. Next step. And this speaks to, again, the data. We wanted to look at where do we have our TOC nurses and why? So we were able to look at the discharges by unit for last year and saw that the majority of our discharges are on the med-surg wards. And so we were able to customize the staffing a little bit better. Next. And by the way, that includes Providence. I didn't want to miss that. Our metrics will be looking at certainly the readmission rate, the ED visits per month, as well as hospitalizations and the cost of care. And then again, looking at those that we've been able to connect with the PCP. And for purposes of connecting the dots between inpatient and outpatient, and we kind of sit in the middle, we want to make sure that the documentation is in Cerner so that they're able to, the providers are able to see what's happening in care coordination. Next.
In the interest of time, I'm going to go quickly through these slides, but please stop me if any questions. Looking at the post-hospital appointments, this answers the question that came up earlier, that at least for internal medicine and family medicine, how many of our patients get seen by our health system? Almost 70–80% are being scheduled, with our health system on discharge. They constitute the bulk of the patients that we see in the hospital. So we take a really universal approach. We set them up with an appointment starting on admission, actually. So that's been one of the success stories that, we have quick scheduling and appointments are issued before discharge. Almost 80% are leaving with an appointment with our health system. But where we still have the opportunity to improve is how quickly we see them. So our average, how far that appointment is, vacillates between 20 to 28 days. And there we're working on, doing better risk stratification, AI. I'm going to contribute to our word cloud for today, virtual care. So some of the tactics we're going to employ to reduce that time to under 14 days. Next slide. Our CHF group is our most mature group. It's led by our cardiologists and now one of our pharmacists. They're trying to reduce the excess days of care and get patients in within 7 days as the AHA measures. There again, we're helping them on discharge. We're seeing them during the hospitalization, getting them prioritized appointments, and the majority are actually being contacted or touched by our transition nurses, over 95%. Next slide. And there we've continued to have fairly good readmission rates for heart failure from historical norms. Next slide. COPD is a intermediate in terms of how mature this group is. They're working on maintaining our already good COPD readmission rate. They're doing a lot of the same things that our heart failure group has already been doing, but some more specific to COPD, which is smoking cessation, inhaler education, and that's been one of the tasks, is getting all the different that are working on this patient population organized. And we're seeing some success stories there, so hopefully more to come on that. Next slide. Our group is the oncology group. Again, we have a higher than other hospital readmission rate for oncology. We'd like to get it down to 14%, which is what other safety nets have as their readmission rate within Vizient. There, I think our opportunity is really having palliative care much more involved, especially early on. The sooner palliative care gets involved, the higher chance that you have a better symptom management for that patient population. Decreased length of stay, which benefits the health system. So these are we've had success where now we have institutional buy-in across all stakeholders that this is a priority area that we need to standardize what we're doing for this particular patient population. And we're increasing the rate of palliative consultation, and we hope to report on that in the next presentations to come. Next slide. Then for renal failure, this is led by two of our nephrologists. We are also similarly trying to reduce our renal readmission rate to 14%, similar to other safety nets. And there, I think the opportunities are, again, close follow-up within our renal clinics. And for dialysis patients, a lot of them return back to our hospital because they left with a marginally acceptable blood count. So, transfusing them before they head to their dialysis center, communicating better with that dialysis center so that they don't, get sent right back, which is no good for, the patient. So that's, I think, one of the easy wins, I think, that we can have for this patient population. Next slide. Any questions?
Any other questions? All right, thank you. Thank you. Thank you. Appreciate it.
Before you all leave, I just want to once again applaud you for your efforts. I think it's just an outstanding report, and look forward to hearing about the follow-up, and whatever we can do with AI,
Okay. So there are no appointments or reappointments being presented, so we'll move to item 4B, which is the EMS and MEC reports. Dr. Akintoran will present the Stroger Hospital Quality Committee summary for informational purposes, and will present the medical staff action items for the committee's consideration.
And Dr. Akintoran is joining us remotely.
Okay.
Yeah, thank you, Mr. Gaza. Good morning, directors.
Good morning.
Yes, sorry I had to arrange to join you virtually this morning instead of in person, as I intended to do. And I just want to thank previous presenters, Dr. Jabbar and Mr. Dan Cruel, and Dr. Mikaitis and Dr. Willie for the next week, and also for your the engagement of our directors. That's really amazing. Thank you. So my report, which is going to be short, the credentials report, which is before you for consideration. That's the report of appointments, reappointments of physicians and other providers, and also some changes, to that. I take the opportunity to kind of highlight the work of our Credentials Committee and the Medical Staff Services Department, that they work very hard to give you a clean report, so that that will make it really much easier for your job to do. So the credential report, there is nothing out of the ordinary there. So if there's any question about that, I will be happy to answer them. And then I'll go directly to the some highlights from the summary report of the EMS committee from the minutes of the HQPS committee for this June 2023. And this is based on the meeting of that committee in April. So some of the highlights there, which just have been projected to you now. Environmental care for all of 2022, there was 0 hazardous material spills. Staff knowledge and participation in the security program was 100% for areas participating in the first quarter of 2023. Laboratory, the proper use of personal protective equipment for lab personnel was 100% for all of 2022. Our phlebotomist hand washing compliance averaged 95.5% for all of 2022. And going to the area of dialysis, dialysis met the 2022 goal of 0% patients having bacteremia in their central lines and AV fistulas. And also the dialysis, they made the 2022 goal of 0% of patients developing peritoneal dialysis infection. There were no action items before the EMS committee arising from this, and there are no action items being presented for you today. Thank you. If there's any questions, I'll be happy to answer those.
Thank you, Doctor. Any questions? Excellent highlights for the month of April. Thank you.
Thank you.
Okay, we'll move to Dr. Mark Loafman, who will present on the medical staff action items on behalf of Dr. Marlon Kirby, who serves as the president of MEC for the committee's consideration.
Great. Good morning, directors.
Good morning.
Almost good afternoon. You've got 2 reports in your packet from 2 consecutive meetings of executive med staff at Provident, both for their May and their June meetings. So they both have slightly different measures, and I'll share both with those quickly with you. So going back from May, pharmacy measures, anticoagulation, a high-risk drug, so warfarin use, several protocols around how to guide that in. So 100% compliance with that on the audit, which is what we expect, and that was really great work. And environmental care rounds on med safety in March was also 100% for the lab, the inpatient pharmacy, outpatient pharmacy, and the OR prep area. So again, those are all high-risk areas where the med security is vital, and again, at 100%. We looked at pharmacy the following month and brought out some findings on barcode administration scanning, so that the numbers are close to goal. In fact, they exceeded the expectation, but are still not at 100%. So they're drilling down on that a little bit. And I think what you can imagine is some of the workarounds that are necessary to quickly get meds to patients when they're brought into the ER before some of the registration fields are completed. So there are some steps nurses take to backfill that, and that's a workaround that we try to work through. So that's getting better, and still a little bit of room for improvement there. So with the med scanning, looking at patient access, going back again to the May meeting, registration accuracy was up to 88%, so it continues to improve in the ER, but still the goal is to get to 100% for that, and also for same-day surgery, almost up in the low 90% range, so improvement seen there. Patient access the following month, looked at, again, a registration, so the ED got up to 100%, and that is what we expect. So they've continued to work a few areas, and one of the things we ask is to back look at errors and see if there was a particular staff member or two, particular time of day or something where this was happening. And I think the ER was successful in uncovering a couple of opportunities for improvement there. Same with same-day surgery. The accuracy got up overall 97% for the year so far. Environment of care for the May meeting, 100% for both participation in the Code Silver drills. There, an opportunity for improvement was identified there, so drilling was done as appropriate, and they got 100%. And same with fire extinguisher. And lastly, inpatient care coordination, which was the topic of the previous conversation. A lot of that going on. So some really good work. Helen Agomo and other team members at Provident do a really good job with this. So denials, we know the insurance companies are quick to deny a claim. We work those down. So they're tracking the percentage that are upheld, so that, you'd like that to be a low number. That's the goal there. And then discharge planning is something even, 7 days a week, 24/7. It goes on. And so having the team involved, we expect that to be done sooner than 72, ideally, but 72 is sort of the cutoff, and they're almost 100% and being able to get that done. So lots of good work. Quality Committee remembers they're meeting at exactly the same time here. So David Kirby from Quality is running that meeting too, but we're going to adjust the meeting timing so we can not conflict with your meeting here today. The credentialing committee has been very busy, as has been the norm at Provident lately. So you've got several credentialing report. Now I think we've got some action on that too, but no action from EMS on either of these fields for you. So that concludes my report. Thank you.
Any questions? Okay, thank you, Dr. Lopez.
Yeah, thank you.
Good report. Let's see, we will move to item C. The 5/18/23 minutes, these were approved by the board at the May meeting, are being presented for the committee's review and discussion if necessary. Are there any corrections that need to be made into the minutes? Okay. So we're at item D on the agenda for a combined motion. I'd like to entertain the following combined motion to approve the following items. Approve item 4B, Shorter Hospital medical staff appointments, reappointments, and changes. Approve item 4B, Provident Hospital medical staff appointments, reappointments, and changes. And accept item 4C, May 18th meeting minutes of the board. Can I have a motion, please?
So move.
Moved by Director Story. I'll make the second. All in favor? Aye.
Aye.
Any opposed? Okay, so the ayes have it, and the combined motion carries. There is no closed session expected today. I'm sorry, Madam Chair. Adjournment, got it. Okay. I was hoping to get through this without needing help, but I'm glad you were there for me. Okay, as the agenda has been exhausted, I'll declare the meeting adjourned. Thank you. Have a good weekend.
Thank you.
Thank you.
Good job.
Oh, yeah, I thought. Okay.